Now, Dr. Hamlin originally came from Australia, and she came here with her husband, the late Dr. Reginald Hamlin, and they co-founded the Fistula, the Addis Ababa Fistula Hospital. And together they pioneered a fistula surgery, which she has been performing for about 50 years now. Is that about right?
55.
55. She's the author of an autobiography, which I really commend to all of you. It's called The Hospital by the River, A Story of Hope. And it was published, I believe, in 2001, and sold something like 50,000 copies. So I do suggest that you read it. She was nominated for the Nobel Prize in 1995, and again, most recently this year. And among her many awards were the Anzac Peace Prize, as well as the Right Livelihood Award. And most recently, she has been referred to by the New York Times as the 21st century's Mother Teresa. And I think that's well said. She's joined by the CEO of the hospital, Martin Andrews, and he manages the hospitals across Ethiopia. And he is originally from Ireland, but he is the father of 3 Ethiopian children. So I want to just start, Dr. Hamlin, with the question about fistula itself, because despite your book, it is not known by all. So I wanted to have a sense of what fistula is, what young women or women are faced with, literally, and what kind of future they can hope to have.
I'll tell you what a fistula is. The fistula we treat is an obstetric fistula, and it's due to a long obstructed labor, with the tissues being pressed on by the baby's head, and a hole develops because the blood supply is cut off, and part of the bladder will drop out as a dead piece of tissue. It's not just a tear, and it's not just a track, as most fistulas in the body are. But usually they're just a track from an internal organ to the outside world. But ours is a big hole due to pressure necrosis of the bladder. The bladder dies because the baby's head is pounding at this organ in front of it, trying to get out. And the rectum is at the back. It's being pounded as well. So this woman may suffer a hole in the bladder and a hole in the rectum. So imagine a beautiful young woman having her first baby, starting labor, thinking by the time my husband comes back from the farm, I'll have the baby in my arms. But she doesn't have the baby in her arms when he comes back in the evening, because she's in obstructed labor. And 5% of all women in the world, whether you live in Europe, whether you live in Africa, whether you live in China, whether you live in the Pacific Islands, get into obstructed labor. And in the Western world, they're helped now by cesarean section or some other skilled sort of delivery. But in Africa, very often there's no help. And certainly in Ethiopia, in the far distant countryside, there's very few doctors available to help a woman when she's in obstructed labor. Unless she can get help, within the first 12 hours, the baby will die inside her. And after the baby's dead, it gets smaller, and she's able to push it out as a stillbirth. And then she finds this dreadful affliction. All her body waste is coming out without control, and her life is ruined. Imagine a woman, a beautiful woman, looking forward to a baby, not always her first baby, but very often it is the first baby. And then she finds that there's no baby, the baby's dead, but that's not such a tragedy as what's happening to her body. She finds she can't control her urine. And about 20% of these women have a hole in the rectum as well, so they can't control their bowel motions. And you imagine a woman just recently married, or maybe she's had 3 or 4 normal deliveries, and then the baby's been in a bad position, and she hasn't been able to get it out, and she's left with a vaginal fistula. So that is the thing that we're treating. It's a hole in the bladder and or the rectum, or both. And so a woman is reduced to absolute poverty, rejection from her society, from everything in her village that makes her happy, She's got no life, and she often will commit suicide and wished she had died with the baby. And this is what we're treating. We're making a new life for these women. They're young and they're beautiful, and they can have more children later on. And we've got now a ward in the hospital where pregnant women that have been repaired can come back to us and wait till they're able to have a cesarean section at our hospital. So that's the story.
Thank you. And what about the psychological side of this?
Yes.
What kind of care are you able to provide
Well,
in
you
that
can talk
regard?
about that, Martin.
Well, yeah, I suppose, you know, that as Dr. Hamlin says, that the social stigma associated with this is huge. So from the moment the patients come to our facilities, you know, we start to try to break down some of those social stigmas that exist and start to make the patients feel comfortable in their environment. But then the care goes on. So after surgery, we have a whole series of rehabilitation and reintegration programs where we try to reintroduce those women back into their communities. And we have psychiatric nurses and social workers and a chaplain, and we can bring in psychiatric doctors as well where appropriate. But many of them need significant help after procedure to be able to get them strong enough to go back to their communities.
And you were saying, Dr. Hamlin, that in Ethiopia, many of these women would not have care. But isn't there a big difference between Addis, for example, and the countryside? Say something about that.
We never have, very seldom do we get a fistula from Addis Ababa, because there are doctors here that are able to help a woman if she's in obstructed labour. She will go to a hospital if she's not delivered in the first 12 hours. She'll go to a hospital, and a gynecologist will be able to deliver the baby, either by cesarean section or some other skilled intervention to deliver the baby vaginally, if it's possible. So I think we've only ever had, in my whole lifetime here, we've only ever had about 3 come from Addis Ababa. And so those are often the women that have come down in the last stages of labour to try and get help. But most of them are delivered safely in this big city. So we don't see many fistulas coming from Addis Ababa at all. They're all from the countryside. And they used to make journeys of enormous difficulty. In the early days when we were here, one woman sat on the bus stop for 6 years trying to get $20 together to come up from the Kenya border to Addis Ababa to be cured. And she sat there, and we wondered why she had a dirty envelope, and inside was a clean letter from a missionary. Would you please cure this girl's fistula? And she'd waited 6 years sitting on the bus stop begging to get the fare to come up to Addis Ababa. So they're reduced to abject poverty. They're rejected by their families because they can't live with the family. They're offensive to other people. She has nowhere to wash her clothes. She creeps out at night to perhaps wash in the river or to wash in the pump. And she doesn't mix with the other village women. Everything in her life that made her happy has disappeared. And so I want you to think of those women suffering now all over Ethiopia. There are hundreds of them that we haven't touched that are suffering in the countryside. And we have to do something about preventing this injury. This is what I'm trying to do. We've set up a midwifery college now, training midwives. We take the midwives from the countryside, high schools. We don't take them from Addis Ababa because they won't go and stay in the country. We take them from their own cities and own towns in the countryside. And we say, would you like to help your women having babies? And many of them want to come to our college to be trained. And we've had 3 graduations, is it?
3 graduations, yeah.
We had 3 graduations since we set up. It's now been made 4 years instead of 3. So last year we didn't have any graduations because the Ministry of Education wanted it to be a 4-year course instead of 3. So we have these girls for 4 years. We take them from the countryside, from a 12th grade student. We ask them if they'd like to be somebody to help their women having babies. And many of them say they'd like to do that as their profession. And so we've been very fortunate because our last Minister of Health, I believe he was here this morning, Dr. Tedros, was very, very kind to us. And he was interested in these women. And he said, you can have antenatal clinics in all the health centres that I've set up. He set up most of the health centres in the countryside, and he's given us 3 rooms whenever we want to have midwives in that health centre, as they could start an antenatal clinic there and look after the women.
And have you been able to engage some of your former patients
Yes.
in helping
Yes.
new patients?
This is a wonderful way to run a fistula hospital. With these girls, sometimes they have to have a very severe operation to cure them, which involves diverting the urine altogether from the vaginal area because their bladder has been destroyed totally, and it's only just the size of a thimble, and it won't hold any urine, so there's no point in repairing that sort of an organ. Or if there's no bladder, you have to do some other diversion type of operation. And so a lot of these little girls, quite a number, I don't know what the percentage is of all the ones we do, but they have to have a bag of urine with a stoma on the abdomen, and like a colostomy, only it's a urostomy. And not only are those girls taken, but other girls that can't get back to the countryside or have some other trouble, they stay on and they become nursing aides in our hospital. And we have a big number of these girls. They work under the sisters, the trained sisters, who do a proper nursing course. And these girls are trained by a tutor sister to give them some nursing skills. They work in the wards under the sisters, and they learn how to look after patients. And they stay on with us, and they're wonderful advertisements, really, for our work, because they're so welcoming to new patients coming. They've been in the same areas, they've been in the countryside, and they know how to treat a country girl. And they make them feel at home straight away. And this is a very good way to run a fistula hospital. I must tell you that the first man to cure a fistula was in America. So all the Americans here should be saying, and I'm very proud, the first fistula surgeon was in Alabama and in the southern states, and he had slave girls who were turned out by the owners of the slaves because they had an obstructed labor and developed a fistula, and they were not wanted. So they said, go, and they just got rid of them. Terrible condition in the USA in those years. Fortunately, it's not there now. But this man was sitting at the edge of the slave area, and these girls would come to him, and he operated on them and couldn't cure them for 9 years before he got a cure. And everyone said, you're a mountebank, you're just practicing on these girls. And all the other doctors despised him. But then he succeeded, and he became very, very famous all over America. And he went all over Europe. He operated on a princess from Spain that had a fistula, and he became very famous. And I've read his life, and he persevered and persevered until he was able to cure his first patient. But it took him 9 years. I think he started in 1845, and he hadn't had a cure until 1855. So it was a long time. But then he became very successful and went all over Europe, all over England, demonstrating his techniques.
Now, you first came here as you and your husbands to, I think it was with the intention of staying 2 or 3 years, working
3 years.
as...
We were going to
3
stay.
years. 3 years. What happened to your plan? What happened to your plan, your 3-year plan?
Well, we started to get these little girls coming up from the countryside, and well, they weren't all small. They were young. Sometimes they were women who had 3 or 4 successful deliveries, and then they got stuck with perhaps the 4th or 5th baby, where the baby is at fault. My husband used to say it's either the passage or the passenger at fault. The passenger is the baby, and the passage is the pelvis, the bones that the baby has to get through to get out. So, what am I talking about now?
What diverted your attention? I mean,
plan.
initially, you didn't know that you would be working on fistula as the problem.
We became so involved with these girls because they became such an enormous number coming down from the countryside. We had a backlog of many, many patients. One day, I remember 36 turned up. I've got a photo of them all in a row with all their little country robes on and holding a stick, some of them. And it was, we were these fistulas had been going on for so long, and nobody had told them that they could be cured. And so that's why we got an enormous number, and we just couldn't walk out and see them being left with no help. And we got very involved, and we loved them, and we loved the work, and we were so excited to be able to make a new life with very little. It was very easy sometimes to cure the simple ones. It was no problem, but we had some difficult challenges as well. But we managed. So
I note that Martin and I have both referred to the women and girls that you've operated on as your patients. You have not used that word, patients. How do you, as patients, how do you see these women who come to you?
I just see them as normal people, and I love them. They're very attractive people, the Ethiopians, I believe, and they're famous for their beauty, the women, not only because they're beautiful, but they're so helpless and so much in need. And we, with all the education we've had and the training, feel we're honored to be able to help them, and to very often help them with very little. And we are so excited by able to see somebody, a new life coming so easily to us.
Now, in some of these cases, there's a chronic need. It's not a total cure. There's ongoing medical need, Martin. So I wanted to have a sense of this sort of infrastructure out there you have for taking care of women with chronic illness.
Sure, yeah. Well, I think as Dr. Hamlin talked about the original hospital in Addis that was set up they eventually opened it in 1974, so it's 40 years on the go now. But since then, we developed 5 regional centres around the country. So they're all miniature hospitals in their own right. Each of them are sort of front line of defence in terms of treatment of fistula. Mm-hmm. Each of them have surgeons, all Ethiopian surgeons. They all have between 30 and 40 beds, that sort of size. And they can treat the straightforward cases. And then Addis has become more of a referral centre where we have more advanced additional services like physiotherapy and urodynamics and other specialist services, and we have our psychiatric team and our social worker team there. So we've developed quite an infrastructure to be able to help all different spectrums of ends of the spectrum in terms of patient care. There's the easy ones that still come and are cured within 3-4 weeks, and they go back to their families and they go back to their husbands, and life goes on. But at the other end of the spectrum, there are some very complicated cases who still need complicated urinary diversions or other urogynecological procedures. They may need years of help before they're even ready for the procedure, and then after the procedure, they might need years of help before they're ready to go back to a community of any sort. So they're the very extreme and acute end, but we're open to all patients, and anybody who comes to our doors are helped, and we don't turn any fistula patients away, no matter what their needs are.
And I should note that they're treated free of charge in the hospital.
Yes.
We have a free hospital. We sometimes have 2 in a bed, and imagine 2 women wetting the bed together. Not very nice, but it's better than being on the streets. And we feel also we get an enormous number that need a lot of physiotherapy, because sometimes they lie in bed thinking, if I keep very still, I keep my legs together and my knees together, this urine will dry up. And they lie like that. One little girl, she lay for 6 years on the floor, and she weighed 24 kilos when she came to us. And her knees were under her chin. She was just curled up like a little chrysalis, because she'd been lying curled up on the floor for 6 years. I said, who's been feeding you? And she was thin as rake because she had a hole in the rectum. And she said, if I eat, the bowel contents come straight out of me. And if I drink, I get urine pouring out. And so she would lay like that for 6 years. And these girls are curable. She's now walking about. She had to have a bag on the abdomen because the bladder had been destroyed. But she's got a new life. And it's just wonderful to give a new person a new life when they're young. Not patching up an old person like I am, not patching me up for a few more years, but we're giving somebody at the beginning of their lives a life. And this is what I want to tell you, that we could eradicate fistulas if we had a midwife in every village in this country, and we had a referral base where they could send the patient to a hospital where we had a doctor who could do a cesarean section or deliver the baby in some other skilled way. So this is what we have to work for.
And is eradication your goal?
Yes, I've seen an enormous improvement over the years, but we haven't yet made fistulas. Fistulas were all over Europe until the beginning of the 20th century. There were fistulas in England, fistulas in Germany, fistulas in Spain. And there were fistulas all over the world. But now there are none in those countries. No obstetric fistulas. They're fistulas from cancer and other diseases like that, but not from obstructed labor. And I would like to see this country start to really get rid of the fistula problem in my lifetime. I've only got a few more years probably, but we're making progress. We've got a midwifery school, and tell them about the man.
I think the whole prevention program that we've been working on, and in conjunction with the government here, that, there have been some huge successful strides made in Ethiopia in the last few years. Dr. Hamlin mentioned a bit about the way we select the midwives and how we train them, but what's critical then is how we follow through with that in terms of our mentoring program, and we make sure that those midwives are effective in the field and that they're delivering babies and that they're supported so that they have a proper referral system and they have an ambulance to call when they have an obstructed labour. Because if midwives are in the field and they start having preventable maternal deaths, then the community will just close down on them and they'll be totally ineffective. And the government here they have seen maternal mortality as a huge priority. It's been stubbornly high in Ethiopia for the last number of years, but they are investing heavily in both constructing health centres around the country and in training midwives. But to make that infrastructure work, there is another big step to be taken. They need to have those midwives working effectively. They need to have proper mentors working with them. They need to have a proper referral basis, and critically, is that referral base to doctors, to train doctors who can perform cesarean sections within a commutable distance or a reasonable distance of the health centres in the countryside. And it's, a lot of the pieces of that jigsaw are there, so there is a real potential that we can see some huge changes in the coming years, but there's still a long way to go to making those resources work effectively and to actually getting the results at the other end. The goodwill is there from the government, but they need to really push hard now at making this investment work for them and to get those results out. Because prevention of maternal death is exactly the same as prevention of fistula. It's the same condition. It's obstructed labour, and it's intervening at the right stage and having the skilled people in the field who can get those women to help when they need it, and screening and of high-risk mothers and everything else. So our programme has been very successful. In the health centres where we're working, we have virtually eliminated preventable maternal death in those catchment areas, but it's a drop in the ocean. We're only in 17 health centres out of 1,600 across the country. We need to upscale that. We need to learn from these good examples, and the government need to be able to follow through with having the referral base there. So it's going in the right direction, certainly.
And of course, maternal mortality has been one of the most stubborn of problems, and amongst the Millennium Development Goals. When you think about it, that's been the one that's made least progress.
Yeah.
And we've lost so many doctors, and I'm very upset because there are more doctors of Ethiopian origin in Washington than the whole of this country. And many of our country hospitals have no doctor for these girls to refer a patient to. And this is a disaster. And I feel that whenever a hospital is built in the countryside, they should build a nurse's home for nurses to go and live there happily in a lovely home, and a doctor's house. They don't provide that. And I'm going to try and see the Minister of Health soon and say, please, when you build a hospital, build somewhere for the people that work in the hospital to live. They can't live just in one room in the hospital. My nephew comes from Australia every year for 3 months just to help because he's worried about these women. And he has just a little room to sleep in. And he could never bring his wife and children there because there's no home for them to live in. But they would attract doctors. A lot of doctors would like to come to this country if they could go into the countryside and help and live in a house that was reasonable with a family. So this is what we must pound on the Ministry of Health to provide for every country hospital. A home for the doctor to live in, a home for the nurses to live in, and then we'll get more and more help into the countryside.
So in a moment, I'm going to on, and that's the research part of it. Is that part of your work as well? There's the treatment, there's the care afterwards, there's the prevention effort, but what about research?
Yes, I mean, because we are such a leading agency in dealing with fistula worldwide, there's nowhere else that has the number of patient load, or the patient load in fistula specifically than we have. So we have, over the years, we have taken a fairly big role in both research and in training of overseas doctors. So we get doctors coming from all over the world to train with us, and we also engage in research programs. Probably not as much of the research as we'd like to do, because it's a challenging area to work in you know, when you already have a limited number of health professionals, but it's something we're really putting a lot of effort into now, and we're trying to partner with some of the universities here to try and take a more institutional approach to research. In the past, it's probably been more individualized, where you get one physician who comes and is passionate about one area of research, and we follow that. We need to take a bigger picture on research, and you know, we are very passionate about having that world-class sort of standard of research, because we are a world leader in fistula treatment, and you know, we have a responsibility to pass that good practice and knowledge on to other countries, because a lot of the other countries are only starting their fistula programs, and you know, we really don't want them to fall into the same mistakes as we might have made, and so they can really learn from the good examples that are there. So,
yeah.
Sure.
So can we turn for questions from the audience? I'm going to keep my eyes peeled, and you don't need to limit it to fistula. You can also talk a little bit about both health systems strengthening and its importance, but also women's health, which was touched upon a little bit in the last panel. Excuse me for doing this with my eyes, but I can't quite see. Is that Masimbi? I've got a light right in my eye. I think that's Masimbi.
I just wanted to say the cases of fistula among women in Africa, we know about them. They have been well documented. But recently, some cases have been brought to our attention about fistula in men, which I still don't know enough about. Have you got any of those cases? Do you hear about them? And what causes fistula for male?
Have you had cases of men suffering from fistula?
Yes, we have had some coming, but we don't do anything for them. We send them off somewhere else,
Yeah.
because
Because you're focused on
obstructive.
a different thing.
obstetric. Yeah. And is there proper care for them in hospitals that are most
I don't think it's very
general?
common with a man to get a fistula in the urethra or in the... makes them incontinent, you mean?
Yeah, there's rectal fistula in men, but it's you know, completely different conditions. It's usually linked to cancer and things like that, and it's not something that we have any particular expertise in or interest in. Our concentration is about obstructive fistula and maternal health. It's all about that. Yeah.
And
So I don't know enough about it to answer the question.
Yeah.
So it's quite a different sort of a fistula too.
Usually, a lot of those types of fistula are linked to cancer care.
And also to venereal disease, you get a little track of infection, and it's just a little track of a hole, and it's called a fistula, but it's completely different. I get a lot of people writing from America saying, we treat fistulas here, but they're nothing like a birth fistula, where you've got a whole, half the bladder missing from pressure, necrosis, death of the tissue.
As you think about this particular health problem for women and in childbirth, is it the nature of this problem that allowed it to go untreated for so long, sort of the stigma associated with it, or is this does this suggest a wider inattention to women's health needs in rural settings, not in Addis, not in major cities, but in rural settings?
Yes, well, I think it was all over the world once. We had a slide of a mummy dug up in the pilgrims with a huge fistula in her bladder. Well, it's been going on since the beginning of time. But only when childbirth became a safe procedure in the beginning of the 20th century, when caesarean section came in, were fistulas really done away with in countries that have plenty of gynecologists that are able to do a caesarean section. But it was all over the world before. And of course, most of these women die undelivered, because once the baby's dead inside them, it becomes infected and they get septicemia very quickly and die. But when the baby's dead, they're also able to push the baby out because the bones collapse. The skull gets soft and she can push the baby out as a stillbirth. And that is why most of these women have a stillborn baby. Very few of them survive with a fistula, with a live baby. And I didn't really...
I think one of the things, the issue with fistula is it is a hidden condition, and a lot of people won't die from fistula. Whereas if you look at most of the investment that's gone into African healthcare over the last number of years, it's all about communicable diseases, HIV, malaria, the big killers. And quality of life is not really considered a big issue. There isn't a lot of investment in quality of life, and this is around quality of life.
Yeah.
With the exception of some of the extreme cases where people get urinary infections and kidney failure, by and large people won't die from fistula, but they will have a miserable life and they will have no quality of life. Yeah. And it's only there are very few organizations who really will take the care to really look into those. Most of the millions and millions of dollars that go into healthcare go into treating HIV, AIDS, malaria, the big killers, and that's where the tradition is. But there is a shift going away from that at the moment, I think.
Yeah. So if we could bring a microphone over to Manu Chandaria and then over to this corner too. Sorry, I can't see you.
Somebody here wants one too.
Thank you.
And was there somebody in the middle? Okay.
Catherine, congratulations. First thing is that you said the midwives should be trained. Does midwife could operate? Can they remove the fistula or something? I'm naive about this.
Can the midwife undertake operations?
Because I'm one of all my siblings. We are all born through midwives. My mother never went to the hospital. The point is that what is required? Because in many countries now in Africa, midwives are now coming back and saying that they should be trained so that they should be able to look after the childbirth. And today, one of the MDGs is child dead at the time of the birth, and the mother also dies or gets hurt and ultimately dies. These are the issues. What I don't understand is that if it requires surgical, then you have to train in that manner rather than just having a midwife deliver.
We actually talked about this at lunch a little bit, and that is the nature of the training that's needed in order to ensure a healthy birth, and what is the role of the midwife? Is the midwife got the training needed?
There's probably two things. One is the midwife can be trained to screen high-risk mothers and to refer those high-risk mothers to somebody who can do an emergency cesarean section. So that's the normal arrangement.
Okay.
And the preference would be that midwives are the front line of defense. They screen the high-risk mothers, and then when so those they can look after very well. And then when they have an emergency case, they can refer them on. The problem here, though, in Ethiopia, in rural Africa generally, is that the referral base is very poor. So where do they refer them to? And the next part of your question is, can the midwives do some of that surgical work to prevent the fistula? And the answer to that question is yes. Midwives can be trained to do cesarean sections. It's a complicated process, and they do need another couple of years education, and they need to qualify, and they need to be mentored, and they need to be trained. But they also need to have the appropriate facilities that are clean. They need to have an operating theatre. They need to have everything else. But we are working with the Ethiopian Midwives Association and other partners to try and look at ways of training midwives to actually do cesarean sections. And they do them successfully in other countries. Here they use health officers to do those instead of midwives. Our preference would be to train the midwives, but that's a longer term program because you've got to get the training right, and then you've got to get everything else right.
The midwife can also diagnose when the baby is the cause of the fistula. If it's lying crosswise, before the labour starts, she can put the baby, by pushing it round, into the right position so that the woman won't come into labour with a baby lying across her stomach instead of up and down. And she can have the head pointing down nicely. And all sorts of things like that she can do. Manoeuvring the baby round before birth into the right position is very important work for the midwife.
And that's the prevention.
Yeah,
that
okay,
is sought.
thanks. I think that clarifies now, that midwives are the one who is the first indicator. The second question is that while we have got lots of people from Africa over here, why do we have to have everybody from outside starting these issues? I'm a chairman of eyes. I'm still the chairman for the ears. I'm still the chairman for the heart. And every time we have to bring doctors from outside. And none of our doctors are prepared to take any time. Either you pay them, they'll come. If you don't pay them, sorry, they're not interested. How can we just put this in the medical curriculum? Give back to society. Because they're just not prepared. And this is some irony. We did 10,000 eyes operations, 6,000 ear operations, but all people coming from outside. This is not on.
Yeah.
And I
And
think
of course
unless we take up this issue, while they are here, why they and not some of us?
Yeah.
Thank you.
And it's sort of a twofold problem, as you're describing, but also, as you noted, there are more Ethiopian doctors in the US than there are in Ethiopia. The brain drain problem is very serious. And so what is the role of providing making it attractive to stay, providing reasonable salaries, given those years of training that are required?
They don't need to stay for life in the countryside. They could go for 2 or 3 years and then another lot go. It wouldn't be as though they were going to be shut out in the countryside and forgotten. They would do a stint out there to help. And I'm sure they would do that if they had somewhere to put their family and to have nice facilities where the children could go to a school and things like that.
Yeah.
There's a whole lot to be done to make it attractive for somebody to be in the countryside.
And yes, over here.
Good afternoon, this is Fortune again.
Hi, Fortune.
Hi. I can see the mood of this topic is very sober. I mean, it gives us a lot to think about. I've been hearing about VVF, since I was a lot younger, and the mentality I had was because of the early marriage that is prominent in Africa. So is there a relationship between early marriage and fistula, or it's just something that can happen to anybody?
Is there a relationship between early marriage and early pregnancy and fistula, or could it happen at any age? Be equally likely at any
Early marriage
age?
certainly comes into it, but we don't have early marriage in many of the provinces now. Just in the north still going on, but it's illegal actually for a girl to marry before she's 18. The government's made a rule that she should be 18 before she marries, but they don't always stick to this. But we don't see. I've never delivered a woman. The youngest girl I ever delivered was 14. I've never had even a 13-year-old, but they can marry early and they don't get pregnant till puberty. And it's often late because of malnutrition. She may not start to have her menstrual periods until she's 15 or 16, or even more. So it's not really a great problem, early marriage, as far as the baby's concerned. And a young woman of 16 can have a baby if she's had a good diet and she's got a normal pelvis. But there are...
The average age of patients coming in are 19, 20, 21, very seldom under 20, sometimes 19, but very seldom. So we don't see it as a huge contributor.
Yes.
Yes, I'm Franny Leotier from Tanzania, and I'm very taken by your commitment and your contribution to African development. And I want to thank you for that. I have 2 questions. One is, what motivates you all these years? What makes you wake up in the morning and get going? If you could share that with us. And the second question is, you said your ambition is to eradicate fistula in Africa. What would it take to do that? What should we mobilize for to get that done? Thank you.
So it's two questions. The first is what motivates you, what gets you out of bed each morning to deal with this very tough problem? And second, if the goal is eradication, what does that require?
To eradicate. Yes, well, I love being here in this country, and it's not a hardship for me to get out of bed and go up to the hospital. And it's just my life, and I've grown up with the countryside, and I love the country women. And I don't know whether this is given to me by God or whether it's just my nature to feel like that. But I love the country women, and I know that their gratitude is so overwhelming to see a girl who's brought to the worst possible condition a woman can get into, not because of any fault of hers, but only because she had a baby that was in the wrong position or she's too small. And then, what was the last thing?
The question was, if the goal is eradication, as it should be, what does that take? What's missing? What's keeping us from arriving at that goal?
Well, I know it can be eradicated. It was eradicated in England. After the beginning of the 20th century, there were very few obstetric fistulas in England. None after the 1920s. No fistulas in England at all, because we had plenty of doctors trained to do caesarean section. And we have to train our doctors here to be able to do a safe caesarean section. It's a simple operation if you know the anatomy of the pelvis and you don't cut a hole in the bladder by mistake. And so there are just a few things you have to be careful of. And we can train the doctors to do the health officers to do caesarean sections. And I think one day we can train the midwives. But I was up in the ward this morning, and there was the first year midwives were there, and they're really like schoolgirls still. They're all like my granddaughters and people like that. They're just young women starting life, and they're in their first year of the midwifery school. And so you can't really think of training her to do a caesarean section at that stage of her life. So we have to get them a bit more mature, but then we could train them. After they graduate as a midwife, they could be trained to do a caesarean section safely, I'm sure. But I think until women's status improves in this country and all over the continent of Africa, women can be trained to do caesarean sections just as well as a man, probably often better.
Thank
So
you.
I'm a great advocate for women's surgery and for women to do things just as much as men. We're all the same, really, except we haven't perhaps got the strength of a man's. Perhaps that's something we're missing.
So it ties us back to our earlier conversations about the status of women. But also, I'm glad that Dr. Shandaria raised the question of brain drain as well, as important as it is. I hope that you will all join me in thanking Dr. Hamlin for her life's work and for being with us today. Wait 1 second. And I don't usually take advantage of the stage for this purpose, but do feel free to join Martin and Dr. Hamlin to talk about the role that philanthropy can play, because that's something we didn't get into because we got so involved in the substance of the issue. But she will stay for a few moments. We're having a bit of a break, so do feel free to enter into a conversation with them both
We
about
would love
that.
you all to come down and visit us, wouldn't we, Martin?
Absolutely, yes.
Anyone would like to come?
More than
Next
welcome.
time, please do. Thank you so much.
Thank you.